I would like initially to thank you again both the organizers of this committee, Manos and Manos, for this great, every time is greater. So we know the Jules Valls about more than 2,000 cases, and he says the best procedure with a low recurrence rate. And the French we know, and we heard also Jean Cany, 95% Latarjet procedures and not a Bankart procedure, and in other countries we have the opposite. Are the French guys the crazy guys? So we know that the osteoarthritis, this is a 24 years follow-up. We have about 52.5% of osteoarthritis after Latarjet procedure. However, we have to see the position of the screws and the position of the graft. And if we see that from this study, the lowest percentage of osteoarthritis is from the French guys. It's from the guys that they have the large amount of the Latarjet and the greatest experience. So even from France, this comes in a study and says that we have osteoarthritis and the lateral bone overhang is the most important and significant factor to have an osteoarthritis after Latarjet procedure. And also, we have in 71.4% an osteoarthritis if you have an overhang bone block, and you have only about 15% of osteoarthritis if it is medial. And I think this not only happens with a Latarjet, but with every procedure that we have a bone block. If you have an overhang bone block, then you probably will have osteoarthritis. And this was the most significant factor. You see these images, you see the direction of the screws. If you have an A ankle, the French guys call this an A ankle. If it's very ankle, the screw or the button or every device you use for the stabilization of the bone block, though you're more prominent to make osteoarthritis and you're more prominent to have an overhang bone block. Luc Favas says that probably if you reattach the capsule, probably you minimize the risk to make osteoarthritis, and this also forgives you some mistakes. However, systematic review from Salem says that probably you have to investigate this more. It's not, we don't really sure about it if you minimize this complication, and we have to study more if the capsule, if you make the capsule and repair the capsule, you minimize this risk. Somebody can say that if you repair the capsule under the glenoid and you make stiff the shoulder, probably you increase the risk to make osteoarthritis. So this is a factor that we have to investigate this in the future. From Randelli, he says that osteoarthritis probably after Latarjet, if you're doing it very well, is not very high. And all the patients, most of the patients have a grade 1 osteoarthritis, and you have symptoms if you have grade 3 or grade 4 stage of osteoarthritis. Again, the lateral and prominent bone block is the most important and risk factor. So does the technique affect your results and the rate of osteoarthritis? So the Mr. Latarjet with the most viewed VUMEDI video makes the best procedure. This mini open Latarjet using a small parallel drill guide is probably the better. So the magician inventor of arthroscopic Latarjet is probably the best procedure because during the arthroscopy you can control everything. Or the Mr. Shoulder and arthroscopic button Latarjet is probably the better. We know that the osteoarthritis from a Boutsiadis, it is a complication. So when I was there in France, they make a very, very good multi-center study and try to find if the technique affect your results. So they compare the open technique, the arthroscopic technique with the screws, and the arthroscopic technique with the button. And it was found that the angle of the inferior screw is probably higher with an arthroscopic Latarjet using the screws. Probably it's a very demanding technique. So this is the reason that recently Nesca Lafaux says that I have changed my technique since this study, and right now he's using an offset. And also from the position of the graft, we have very lateral graft using the arthroscopic Latarjet using the screws and probably with some buttons. It's probably some mistake with the offset that you're using with the guide from posteriorly not always respects this 5 millimeter, and sometimes it's overhand. And the same happens at the lower part, at the 25 lower part below the equator. We have two lateral coracoid grafts, either with an arthrovis or an arthrobaton, and sometimes the open, it seems to be more safe regarding the position of the graft. Also, regarding the position, we see this doesn't affect the osteoarthritis, probably the clinical results. It's better to put your graft below the equator, and the guide from the Pascal Boileau seems to be better. So for me right now, in mini open Latarjet using a guide, it's not very, very difficult. You make this small incision. You have to start with a larger incision, but it's about 3-4 centimeters. And you cut the pect minor, you make the osteotomy, everything is the same like the open, you refresh the bone, you measure it. I think it's very, very important to measure it, and sometimes to correct it, the lateral side that could be at the joint, to remove some small bone that could be inside the joint. And this is the most important. You put the drill guide, and with the drill guide right now, you can control the position of the graft. So the split, this is a good point. That's a small tendinous portion there. It's in the muscle belly, and there is a small tendon always. It's the lower third of the subscap, and I think it's a very good position to make your split. You find the capsule, refresh the bone, and you see directly the articular surface. And with a guide, you can control it. It's not blind. You can put it medial, lateral. You see always your articular surface, and you beat parallel. So and finally, for the triple blocking mechanism, also you suture the capsule. This is the final result, and you can see also the images. So we also make a study, and we check if this drill guide can give us better results regarding the position of the coracoid graft. And yes, we found in the sagittal plane that we put it in 85%. It was a little bit, it was better below the equator compared with the freehand technique of the Zilfals. But the most important, it was slightly lateral only in about 4%. While with the freehand technique, we had about 27%, a little bit overhanging. So using this guide, probably you should end up with radius like that, with parallel screws, not anchored screws, and also with a flush positioned coracoid graft on the front of the glenoid. However, the screws are always good? We have made a cadaveric study, and we have found in 100 cadavers that the use of the 4.5 screws do not respect a safe distance. Is the principles of AEO that we cannot break the graft or to be the screw inside the joint. So with the 3.75 millimeter screws that I'm using right now, it's 85%. There is a safe distance, but in some cases you have to use a button, and it's better. So with the small coracoid grafts, right now, some cases I'm doing preoperative planning of my patients, and with the 3D reconstruction, I measure my coracoid graft. So in some cases, I think that we have to use an arthroscopic Latarjet using a button, only one button, and to avoid breaking the coracoid or to have a screw excessive inside the joint. So with a drill guide that we're using for a bone block, for a Latarjet, for a posterior guide from the Smith & Nephew, you put it below the equator. It's a very good instrument for making the split, and finally you take your graft inside the joint. So this is the position of the graft from intra-articular view, and this is the final image. And also the CT scan. I have to admit that the healing of the graft is slower, and also the rehabilitation of the patients using buttons is longer than with the screws. I don't feel very secure with the button to mobilize directly the patients. However, we have to admit, Latarjet remains a difficult procedure. For the learning curve to be slightly safe with the open, you almost need 22 open procedures. For the arthroscopic, I think 40 procedures you need to be safe, not to damage a very young patient. So the take-home message, the lateral positioning of the graft is the most important factor. Probably for the osteoarthritis, the previous episodes of instability or a previous surgery, because in most cases and in most countries right now, besides France, it's a revision procedure. It has a learning curve, a strong learning curve. Try to begin with an open procedure. Take your time. Take your nurse, take your anesthetist. I need time to perform correctly a Latarjet procedure. But we have to admit that it's a over 50 years old technique that the principles remains the same. So I think we have a very good French solution beside the Rafales right now, even arthroscopic or an Epimini open, and I give the 3 stars on Michelin to Zilvals. However, Latarjet is like a flight, and you have to be careful because the flight you can fall easily. Thank you for your attention.